What up, Josh Rubin from Psoas Healing and Performance. Today I want to talk about the iliopsoas muscle. Now there's a lot of, I would say, controversy about this muscle, what it does, what it originates, what it inserts, what's in it. So it's major, minor, all these different things. So what I want to talk about today is the iliopsoas muscle, and then go into the gym again and show you some basic techniques, very basic, on how to pump the psoas muscle as a whole, as well as to pump the tendon and the anterior bursa of the psoas muscle. Now, some important things about the psoas is we have to know where it originates and where it inserts. The thing that most people don't really know, and if you study the work of Kapanji, he actually shows this, there's actually an anterior sheath and a posterior sheath to the iliopsoas. Now, the posterior sheath originates, some people say, from T12 to L5 transverse processes. Some people say L1 to L5 transverse processes, and that's the posterior sheath, more posterior in the body. And it goes from basically the inferior part of T12 to the superior part of L5 transverse processes. Same thing with the anterior sheath of the psoas muscle, which is more anterior in the body, and that actually attaches to the vertebral bodies and the discs of the lumbar spine. Once again, some people say the inferior part of T12 to the superior part of L5. Some people say L1 to L5 vertebral discs and bodies. The bottom line is it goes from T12 L1-ish to L5 posterior fibers on the transverse processes of the disc of the vertebral body, and the anterior sheath actually attaches, originates on the vertebral bodies and the discs itself. So the psoas muscle can have an influence on the spine, the mechanics of the lumbar spine, as well as the discs. You have to think about that. Now, another interesting point about this is the lumbar plexus, which serves the lower extremity, actually passes right through the anterior and posterior sheath. So it can easily be affected by any type of biomechanical, kinematic, and anatomical dysfunction in this muscle that's being created from the muscle or somewhere else in the body, from a bone, ligament, and so forth, or even organ. Now, what does this muscle do? Well, if the spine is fixed by certain muscles like the erector spinae, the inner unit, the glutes, you'll actually get a flexion of the hip. Now, if the femur is fixed and the glutes are working properly to fix the pelvis, you're actually going to get an increased lordosis in the spine. If the spine is if the femur is fixed, but the glutes are not working properly, and they're not fixing the pelvis, you'll actually get an anteversion on anterior rotation of the innominate, or the ilium, like most people call it, but it's actually the innominate, because the innominate is the ilium, pubis, and ischium. It's three bones, embryologically. So you get an anterior rotation in the sagittal plane of the ilium. It actually acts on the hip. It actually flexes, adducts, and internally rotates the hip. It actually causes outflare of the sacrum. And at the same time, it can actually cause a ipsilateral side bending of the lumbar spine and a contralateral rotation if the femur is fixed. So that's natural biomechanics. You'll get an ipsilateral side flexion. If the right psoas is working, or it's working unilaterally, you're going to get a right side flexion and a left rotation of the lumbar spine. So it's an ipsilateral side bender and contralateral rotator. Some other interesting points about the psoas muscle is the kidney actually sits right on top of the psoas, and I've talked about this before. Kind of like a train on a train track. And every time you walk, the psoas and kidney kind of fascially move on one another. So a lot of people that do have, kidney pain or psoas pain or tension deep in the, lateral to anterior part of the side of their body, a lot of the times it could be the fascial connection between the psoas and the kidney. So that's something you want to get looked at by an osteopath or a visceral massage therapist. Now, another important point about why we want to pump this muscle is to bring nutrients to the muscle, to relax the muscle, to maybe use it as a preparatory technique when we're maybe working more locally in that area to different bones or ligaments or organs. But at the same time, when you pump this muscle, you're actually getting a general pumping technique of, it's more generalized, we could say it's more regional, of the triangle of Scarpa, which some people call the femoral triangle. And it's basically superior, it's the inguinal ligament, because the psoas goes under the inguinal ligament. Medially, it's the adductor longus, and laterally, it's the sartorius, and the floor of the psoas is actually part of the triangle of Scarpa. Now, this triangle of Scarpa, all these different structures, the femoral nerve, femoral artery, femoral vein, femoral sheath, and the lacunar ligament actually are in this area. So you get a general, more regional freeing of these structures, especially the femoral artery and vein, which can get impinged, cause varicose veins, lymphatic issues, swelling, pain, all these different things. So doing these pumping techniques, you'll actually get a general pumping of the triangular scarpa, which I mentioned is the inguinal ligament, adductor longus. You get some pectineal fascia. You get the psoas, as well as the femoral artery, vein, nerve, sheath, and certain ligaments like the lacunar ligament. So hopefully you enjoyed this general education on the psoas, what it does, where it is, where it originates, inserts. It actually inserts onto the lesser trochanter of the hip. That's why it can actually create not only sacral movements, lumbar movements, ilium movements, and hip movements. So we have to think about all these things in a more integrative sense than just, oh, it flexes the hip and causes anterior rotation. It does so much more. Like I mentioned, it actually causes outflare of the sacrum. It has a profound effect on the sacrum, the lumbar spine, ilium, and hip, depending on what is fixed and what's not fixed, or what's working properly and not working properly. So enough of me talking. Let's go in the gym and just do some general... All right, we're in the gym with my beautiful wife, Jeanne Rubin. The first pumping technique I'm going to show you is just a general pump of the psoas muscle. Okay? So the basic premise is you want the patient's hip flex, knee flexion, triple flexion basically, ankle, knee, and hip. What do you say, this is about 45 degrees, something like that. You just don't want them way back here, but it also depends on what's going on at the ilium. So there's a lot of things I can't show you here on YouTube, but just to show you a general pump. You want one hand on the ASIS, and that's kind of like your blocking mechanism, and you want to basically apply a very small cephalic tension on the ASIS, not down, but this way. This hand is on the femur, right by the knee. And what you want to do, you don't want to pull with your arm. You actually just want to lean back. And as you lean back, this cephalic tension is creating elongation in the muscle. So you lean back. She's going to inhale. And she exhales on 2/3 exhalation. I release slowly. Release this one slowly. And then I pull back into the tension. Inhale. She exhales. I keep that tension 2/3. I release. Not a full release with this arm, but just a release with the, what we call a lemniscat of the body, the rhythm of the body. So what I'm doing is I'm here and here. She inhales, I pull back. She exhales. On 2/3 exhalations, I release. She's creating a nice pumping mechanism in the psoas. We'll do it again. She inhales, exhales, and I slowly release this one. Some people will do more of like, I'll take this one away. They'll do more of a, as she exhales, more of a fast release and then come back. It really depends on the technique, the person, and what you're trying to accomplish. Okay? Let's move on to the second one. So the next pumping technique actually pumps the bursa of the psoas, because anytime the trochanter and the acetabulum are anterior, you get a lot of friction in the psoas, so you can pump the bursa. When you do this, you always want to follow the head of the femur. So you want to make sure that the popliteal fossa is on your shoulder. Now, of course, I could use a smaller table. Have your fist right under the greater trochanter, right on the femur here, on the more lateral. So you don't want it right under their butt on the sciatic nerve, kind of on the femur. And what she's going to do is, I'm going to move my arm. I keep my arm here. She's going to press into extension into my shoulder. I'm going to follow with my fist, right, which pushes the greater trochanter or the acetabulum or part of the femur anteriorly. She's going to press and inhale, and then she's going to relax and exhale. I'm going to keep that tension and then release. Now you can release with your fist, or you can release with a flat hand. Okay, either one. So I'm going to show you just moving so you can see it. So you're under here, a little bit laterally. She's basically going to push. I follow, she inhales, and then she exhales. I keep that tension to push it anteriorly, 2/3. I release, dropping it more posteriorly. Now when your client goes into hip extension, they're not pushing up here, they're pushing this way. Okay, and it's not 100 pounds of pressure, it's a light pressure. So I'm here, she pushes, inhale, I follow, she exhales, I keep that tension, 2/3 exhale, I release. Okay, so that pumps the bursa of the psoas. All right, this next one is for pumping the hip and extension, but it actually pumps the psoas tendons in the anterior capsule of the coxfemoral joint. So it's a great pumping for just the psoas, the hip and extension, as well as the anterior capsule of the coxfemoral joint. So what you want to do is, you want to look at table height. These aren't optimal table heights. We don't have an electric table. I'm working on it. So have your client come a little bit closer to the edge of the table. Now I kind of have to maneuver myself so you can see this stuff. But you want the client hip and extension. Now this is more of a passive one. You're basically going to put your hand on the femur, or the greater trochanter. You don't want your hand right on the sciatic nerve over the piriformis, right? You're going to create dysfunction by doing that, so be very careful. So you want to be a little bit more lateral, more on the, the joint, we could say, just of the overall femur and innominate, where they kind of meet in a sense. And you want to be more on the femur because you want to be pushing it anteriorly. So you're going to wrap your arm around like this on the head of the femur. Now what you're going to do is you want your arm bent at 90 degrees, and you're going to have your patient kind of lift their leg, and you're going to loop your arm underneath just like this, okay, at 90 degrees, because you're going to create extension of the hip passively on inhalation. So the key points in this, as I mentioned, is you don't want to be on the sciatic nerve. You want to be more on the coxfemoral joint on the head of the femur. You want to have a 90-degree bend at the elbow, because as she inhales, she's going to inhale. I'm going to push the hip and extension, the head of the femur anteriorly. And as she exhales, I'm going to hold that, and then release the extension, hold the femur anteriorly, and then release everything. So she inhales, head of the femur anteriorly, with my right arm, more cephalic hand, hip and extension, kind of like a seesaw. With my left arm, she's going to exhale on 2/3 exhalation, release the extension, and release the cephalic hand, which is pushing the head of the femur anteriorly. One more time. She inhales, head of the femur anteriorly with my cephalic hand, hip and extension with my more caudal hand. She exhales 2/3, release the extension on the left arm, more caudal, and release the head of the femur anteriorly with a more cephalic hand. Hopefully you've enjoyed these YouTube clips showing you some basic pumping techniques of psoas. There's a lot more, but I don't want to share with this stuff with you guys. I don't know, was that English? I want to share this stuff with you guys from the stuff I've been learning in Canada, and I'll check you guys later.